Hello, guys. Um, I want to get this out there. Here is our hematology lecture. We will only be doing lectures as a recorded lecture. I'm trying a new thing of recording on PowerPoint and then loading it up to YouTube, so that it's easier for you guys when you guys are listening to it, so you can stop it and start it wherever, or I'm not sure if you can listen to it in your car with Zoom, but I know you can with YouTube. So I wanted to get this out to YouTube. I know Hillary's using Camtasia, I believe, and then uploading to YouTube. But this will be where your lectures are, the recorded portion of them. So like we just opened up the class and I had some issues come up that I didn't get this recorded. Well, actually I recorded it and then I lost it. It got erased. So I'm recording it again. But you'll have this the first week, and then the next week we'll meet in person and we'll do in-class activities that help you learn, whether they're case studies, whether they're questions. So for this one, I know there are a lot of questions in our Heme PowerPoint. So I'm going to skip them while I'm lecturing, but we will go over them next week when we are in class together. And that way I can go through and discuss, because the questions, not only do they have important material in them, but they have ways to look at a question to answer it. I know Michelle will be meeting with you guys or with us on Monday, and give you tips and tricks and all of that. So I just kind of tie some of those in while I'm teaching. So anyways, let's get started. Here's our hematology lecture. So getting first started, talk about white blood cells. White blood cells, to kind of keep them straight, think of them as soldiers or fighters. They're the ones that keep us safe. They give us protection from, whether it be infection or inflammation or even allergies and even cancer. But there are little soldiers that come in and fight the war when we have something that's introduced to our bodies. Like I said, infection, inflammation, allergies, cancer. Normal range for a white blood cell count. You can look at it as 5 to 10. You can look at it as 5,000 to 10,000. However, it helps you to keep it straight. Also, in the NCLEX world, they have started providing lab value ranges on the NCLEX. So that's what we do in CHA. If we have a blood work question or a lab question, we have normal range in parentheses. But your world is not going to be an NCLEX world all the time. So I do want you guys to start getting familiar with your labs. If you're not memorizing, all the labs that you might see once every 6 years, that's fine. But I want you guys to be super familiar with all I don't want to say normal, but the frequently used ones, the white count, the red blood cell count, the hemoglobins, the INRs, all of that. I want you to have it in your back pocket. So when you're on clinical or when you actually get out on the floor, you're not relying on a piece of paper to say, oh yeah, is this normal? Is this not? So I really want you guys to start being more familiar with it. I don't go into a whole lot. There's a nice packet that we'll pull up and look at next week. But I do want you guys to become familiar with stuff, because just even though we give you the ranges are only a small portion of what we want you to take away here in CHA. So, all right, enough of my soapbox. All right, so getting into our left shift. You guys may have heard this. Sorry, I have two computer screens going, so you get like half my face, whatever. You guys may have heard this in places. When we are looking for a left shift, we are looking at the bands. It's normal to have some, like 3 to 6, but once that number increases, we're looking at a bacterial infection. So not only do we have an elevated white count, but we also have an elevated band count. That's what it means with shift to the left or left shift. Another one I want you to be familiar with is the absolute neutrophil count or the ANC. You don't need to worry about knowing this formula. Um, it is, when labs are done, it is calculated for you. But I do want you to know what it means. So when we have an absolute neutrophil count, um, it's the same idea as like a high white count or a low white count, because neutrophils are part of the white blood cells. So if we have a high ANC, we're looking at infection. If we have a low ANC, we're looking at a very high risk for infection. Um, we can, like I said, we can discuss this more in person, but make sure you guys are reviewing the ANC and what it means. All right. So getting into changes when folks get older. There are a lot of changes. They're pretty much straightforward. They make sense. So in elderly people, they have a decrease in blood volume because they have lower plasma proteins. Their bone marrow is not producing as many blood cells because our bone marrow is where all of our cells are produced. So their bone marrow isn't functioning as well. It's old. It's not working as well. Our red blood cell and white blood cell counts are lower. Yep, because our bone marrow isn't producing it as much because our bone marrow is tired. Remember when I talked about white counts, think of them as soldiers? Um, Once people age, those white blood cells or lymphocytes, they're not as reactive. They're tired. Um, they're worn out. So they're not going to be as reactive to the antigens that are introduced to the body, and the immune system is going to tank. Hemoglobin levels are going to be lower. The red blood cells are tired, and white blood cells. If somebody is introduced to an infection and the body starts to fight it off, those white counts are not going to get as high as, so say a 30-year-old gets a UTI, their white count might be 20. An elderly person gets a UTI, their white count might be 15. They're just not going to jump as high because those the white blood cells as people age are tired too. All right. All right. This is just a slide that tells you all of the disease processes that we're going to be talking about: sickle cell, aplastic, hemolytic, polycythemia vera, thalassemia, leukemias, which is the ALL, the CLL, the CML, multiple myeloma, thrombocytopenic purpura, hemophilia, von Willebrand, DIC, um, heparin-induced thrombocytopenia. We're going to talk some more about anemia guidelines, and then we're going to talk about transfusions. I get quite a few of you in skills, and we'll go deeper into transfusions. I usually leave that for the skills, but since we're doing heme first this time, we'll go over quite a bit. All right, so our first one is sickle cell anemia. So if you look here on the slide with the white background, there's a normal red blood cell and a sickle cell. Part of it's cut off because that's just the way the slide worked, apparently. But anyways, our normal red blood cells, they're round, they're slippery, there's no jagged edges, they're nice, and they flow through the bloodstream nice and smooth. It doesn't get caught up on anything. When we have someone with sickle cell anemia or sickle cell trait, when their oxygen levels are depleted or um, their whole body's dehydrated, or we'll get into that in a second, um, those red blood cells kind of suck in on each other and they turn into like a C or a sickle cell. Um, it's kind of like it, um, So that becomes a problem when we look at the picture with the blue background. If you look at it, you see the red blood cells going through the vascular system, and it's just flowing smoothly, not catching caught up on anything. But if you look at the sickle cell, you see these C-shaped red blood cells or like the broken pieces because they do break because their lifespan is so much shorter than a regular red blood cell. But they do break and become sickled. So now when they're going through the vascular system, it's catching up and causing obstruction. So therefore, it's causing the blood to not get to the areas we need it to. It's causing tissue ischemia as hypoxia in the tissues. Um, it can cause a whole lot of things. So getting into the pathophys of it, um, sickle cell anemia is a genetic disorder. The kid needs to get a gene from each parent. So it depends on if the parent is a sickle cell, if they have sickle cell anemia or if they just have the sickle cell trait. Generally, the hemoglobin A has two alpha chains and two beta chains. They're nice and healthy. But when somebody has sickle cell anemia, at least 40% of their hemoglobin is this hemoglobin S, which has the two normal alpha chains and two abnormal beta chains. So that's what the difference is they have a different type of hemoglobin that's more susceptible to dehydration, deoxygenation, all of the things. But it has to be at least 40% of their hemoglobin is the hemoglobin S to make them a sickle cell anemia. So hemoglobin S, like I said, is very, very, very susceptible to a low oxygen. So if somebody has pneumonia and their oxygen levels are decreasing, or they're scuba diving and their oxygen decreases, um, that's what's going to cause these hemoglobin S's, the red blood cells, to sickle. They get sticky and clumpy and they cause obstructions and um, then therefore they're not getting enough perfusion into their tissues. So these tissues are actually becoming ischemic. If it gets severe enough, it's called a vaso-occlusive event. Just basically, it's occluding the vessels. Um, and so it's very, very painful for these folks. Overall, the biggest concern with sickle cell anemia is that inadequate tissue perfusion and the tissue ischemia. Anytime tissues die, it's super, super painful. Things that are going to cause those red blood cells to sickle, hypoxia, I've said it a million times, so low oxygen saturation, dehydration, because the blood is going to be super saturated with these sickled cells. Infection can cause a sickle cell crisis, venous stasis can cause it, pregnancy, especially in pregnancy, the blood is much richer, it's got a lot more things going through it. Alcohol can cause it. Alcohol also causes dehydration, so you see how that works. High altitudes like mountain climbing um, can also be low altitudes like scuba diving. Temperature extremes, whether it's really, really hot or really, really cold, that will set somebody into a sickle cell crisis. Strenuous exercise, a lot of cardio. Um, the harder they exercise, the more at risk they are. Stress, because stress causes a lot of stuff. Anesthesia is a big one for causing sickle cell crisis. So in our folks that are diagnosed with sickle cell, we need to make sure that when they're going under for surgery, we need to make sure that they're coming back up. And then smoking will also cause the cells to sickle. All right. So symptoms. When somebody comes in with a questionable possible sickle cell crisis, there are a few things that we're going to assess. A big thing that we need to look at is their history. Have they ever had a previous crisis? Um, And if they have, we need to ask them how severe it got, you know, um, what caused it, and if there was any treatment that worked versus any treatment that didn't work. We're going to ask them if they've had any exposure to a recent illness, because remember, infection can cause a crisis. Their recent activities, were they doing a whole lot of cardio? Were they scuba diving? Were they climbing mountains? How much did they have for intake in the past 24 hours? Because there's that dehydration factor again. Did they have any exposure to super hot, super cold? Did they have any change in altitude? Mountain climbing, alpine, plains? Sorry, my nose is. Planes, or scuba diving? Have they taken any drugs, whether they're legal prescription meds or if they're street drugs? Because either one of those can cause a sickle cell crisis. There's exercise again, trauma, sleep patterns, um, and their degree of fatigue. How tired are they? Then on to our physical assessment. The number one thing that we are going to look at um, and treat is pain. Um, so because that they have decreased tissue perfusion and those tissues are becoming ischemic, they're going to be in a lot of pain. Um, have them rate their pain, have them describe it, just so we can know exactly what's going on. Our cardiac assessment, we're going to look for any shortness of breath, their fatigue, any murmurs, um, and then we're going to complete our CMS checks. I wish we were in person so I could ask you questions, but we're doing CMS checks because if you think about the pathophys of sickle cell, it can cause obstructions and cause that the blood's not getting to the extremities. So that's why we're checking our color, movement, sensation to make sure that they're having blood flow to their feet, to their fingers, anywhere that that may be blocked off from the sickle cell. Another thing that we have to watch for is acute chest syndrome. This is caused by a respiratory infection or a fat embolism or even debris from those sickled cells. Remember, they sickle, but they also break off because they're brittle. Um, so it might be caused by debris from that. Um, Basically, the symptoms are about the same as pneumonia: the shortness of breath, pain with increased breathing. But it can lead to respiratory failure and then start shutting down the rest of their organs. Um, this acute chest syndrome is actually the cause when someone says they die that they somebody bleh. When somebody dies from sickle cell anemia, this is how they die, is the acute chest syndrome. Some other symptoms would be priapism. Their skin might be cyanotic or it might be pale. We're going to see jaundice. Because remember, I told you the red blood cells have a very, very short life as compared to healthy red blood cells. So when those red blood cells are destroyed, they're releasing the bilirubin, which is what causes the jaundice. We're going to see ulcers on their lower extremities because when somebody has poor perfusion, or venous stasis. You guys have heard of venous stasis ulcers? That's what this is. There's poor perfusion to the lower extremities, so we're going to see ulcers on their lower legs. We're going to see damage to their spleen and liver because that's where we store our blood cells. Kidney damage, we're going to see damage to those nephrons because those sickle cells are going through and blocking up the blood flow to the kidneys. So we have damage to the nephrons. And since the kidneys aren't working appropriately because of these not having enough blood flow, we're going to see decreased urine output. Musculoskeletal symptoms, we're going to see damage to joints because that's a lot of times where those sickle cells congregate. Um, if it reaches the brain, we could see things like seizures, we could see strokes. So think of like a blood clot in the brain. And then some of the psychosocial things that we need to watch for are cognitive deficit, and even behavioral changes because that brain is affected. There's could be microclots, there could be major clots, but we might see some behavioral issues too. Hemoglobin S in a crisis is 80 to 90% of the hemoglobin. We're going to see a low hematocrit because, like I said, the short lifespan of those red blood cells. Um, we're going to see a high reticulocyte count caused by this long-term inflammation. We also see high reticulocyte counts in jaundice, so you can see how they're kind of linked together. Um, Total bilirubin's going to be high because of the damage to the red blood cells and the liver. And our white count is going to be high because they're going to have a chronic inflammation. Pause this for a second. So imaging, we're going to see some changes. So like I said, the sickle cell red blood cells kind of congregate in the joints, so we're going to see necrosis in the joints and it's going to start destroying the joints. If we look at their skull, we can actually see like a crew cut appearance because that bone marrow is overstimulated and producing more and more and more. Treatment of our sickle cell folks. Number one is to treat the precipitating event. Once we reoxygenate our folks, once we rehydrate our folks, those sickled cells go back to that nice normal round shape. Oxygen levels, we need to have them at a normal level. We need to make sure we're getting rid of if there's any clots. So we're restoring all that tissue perfusion. The problem is that sickle cell may actually cause permanent damage to the body, and these cells can also be more fragile because once they've sickled, they sickle a lot easier. Hope that makes sense. And then I just have a little FYI here. A lifespan of a sickled red blood cell is 10 to 20 days. The lifespan of a regular healthy red blood cell is 120 days. So it's much, much shorter. Drug therapy for our sickle cell folks. Number one, we're going to be giving them IV analgesics, or they're going to be on a PCA pump. The first 24 to 48 hours, definitely IV opioids. Morphine, hydromorphone, or Dilaudid will be our drug of choice. Once we start fixing the causative factor of the sickle cell crisis, then we can taper down to maybe some oral meds, oral oxy or oral Vicodin, something that we're tapering them down to an oral dose so they can go home because they can't be home on an IV pain med regimen. Some of the other meds that we give to our sickle cell folks. Number one is hydroxyurea. It helps produce the hemoglobin F. Hydroxyurea will actually reduce the sickling episodes by suppressing the bone marrow function. Because remember I said the bone marrow is overactive, and that's why we have the different skull changes. But when the bone marrow function is suppressed, that also puts us at a huge risk for infection because it's not producing all of our soldiers our white counts. Another one is Endari. They just increase the levels of glutamine, so it helps those red blood cells live longer and decrease their sickling. And then there's another one that I cannot say, but it's a monthly infusion, and it reduces the vaso-occlusive crisis. Another thing we need to do is fluids. Make sure they are almost overhydrated. We're going to be giving them hypotonics so we can pull the fluid where they need to go. Other things that we're going to use are heat, distraction, relaxation, aromatherapy, therapeutic touch. If we're using heat, just remember that if there's an infection, we cannot put heat on an infection, um, whether they ask for it or not. But if there is no infection, we can use heat to dilate the blood vessels, so it makes it easier for the blood to flow through. So it's getting to, the toes, the fingers. Um, it's easier for those sickled cells and the regular cells to get to where it needs to go. Complications of our sickle cell, hemolytic anemia, because the red blood cells are being destroyed so fast. You'll also hear hemolytic anemia when we start talking about blood transfusions. And sickle cell disease crisis. This is where those cells are having extensive sickling. It depends on the patient. And again, it's caused by low oxygen levels or hypoxemia. Long-term issues that we need to be worried about are small infarcted areas. That just means that, maybe the toes, there's a blockage somewhere before the toes, and so the toes aren't getting enough blood. Scar tissue is going to build up. And then organ failure. Big ones are spleen, liver, heart, kidneys, brain, and the joints are the major ones, but it also affects the bones and the retina. So if a mom has the sickle cell gene and the dad does not, they can still pass this, but it's called a sickle cell trait. They may have some symptoms, but they are much less, they're not as severe, because it's not to an extent where somebody with sickle cell disease. So if somebody with sickle cell disease, mom has it, dad has it. But sickle cell trait, only one parent has it. All right. We're gonna skip the questions. We'll go over them next week in class. So getting into polycythemia vera. I just want to point out real quick on the slide, you can use these to study. These are great pictures to study from. But I kind of want to show you an actual picture of polycythemia vera. So if you're looking at the slide with the blue background, there's a normal concentration of red blood cells, and then there's polycythemia vera, which has a whole lot of red blood cells. And they're not even all completely mature red blood cells, but there's a lot of them. So polycythemia vera, there is no cellular regulation. There's nothing regulating how many cells are produced. It's basically a cancer of the red blood cells. Like I said, it's a higher than normal number of those red blood cells. That blood is hyperviscous or thick. It's thick and sludgy. Hemoglobins, their hemoglobin is super high. 18 in men, 16 in women. But there's just a whole lot of red blood cells. I'm not sure if I have it on here about COPD years or not. Um, with polycythemia vera, the big things we're going to see is the hypercellularity. So we're going to have a massive amount of red blood cells, and we're going to have extra leukocytes, and we're going to have extra platelets. So we're having a whole lot of everything, but a massive amount of red blood cells. Assessment, our folks, we're going to see they're dark purple, they're cyanotic, they're flushed because they have too many red blood cells, and so that's what's showing up at the surface. They're going to be itchy because there's garbage as well. Hypertension, because the heart is working harder to force this thick, sludgy blood around. Huge risk for thrombosis, because we have an increase in platelets. We have thick, sludgy blood that is not moving as fast. So there are huge risks for blood clots. Poor perfusion. All the cells have a shorter lifespan. So they're going in, they're being broken down, but the debris and stuff is still left in the vascular system, so that makes the blood even thicker. Debris includes the uric acid and the potassium, so that leaves us at a high risk for developing gout and hyperkalemia with polycythemia vera. They're having severe hypoxia, and then they're not able to clot, and they're at a risk for bleeding. So just to give you kind of an idea, if you see a COPD, they're generally kind of purplish, kind of ruddy color, because their oxygen levels are low as a normal. They're chronically low oxygen levels, so that stimulates the body to produce more red blood cells by the process of erythropoietin. But they're overproducing. So a lot of times we will see our COPD folks develop into the polycythemia vera. Treatment, they're going to have phlebotomy with apheresis, which just means it's a therapeutic blood draw. They're having blood removed, like 500 cc's or 500 mLs at a time, and then it just goes in the garbage. We want them to increase their fluid intake because their blood is so thick and sludgy that we need to dilute it somehow. They're going to be on anticoagulants or aspirin, because we don't want them to throw clots. It's fine. They're also going to be on hydroxyurea, which, like I said, that was for sickle cell as well. But always remember that this causes the bone marrow to not function as properly, so we're a huge risk for infections. All right, so that is polycythemia vera. Thalassemia. As you can see, there's a picture of a boy here. You can kind of see how his face is a little bit misshapen. The biggest thing with thalassemia is the blood cells are not that normal, nice round shape. They might be square. They're just deformed. The symptoms we're gonna see, they're gonna be pale. They're gonna be smaller because they're not gonna grow as well. Puberty might be delayed. They're gonna hit puberty a lot later. Facial changes, like I showed, like with this. Oh, I guess I can't go back up. With the boy, the foreheads are kind of slanted a little bit more. We're gonna see bronze skin, and we're gonna see hepatosplenomegaly. So the liver and the spleen are gonna be larger. And what it is basically just the hemoglobin is abnormal when it's made. Diagnostics for thalassemia, we're going to do a CBC because that includes our red count to see what exactly is going on. Reticulocyte count, because if we have red blood cells being broken down, we're at a huge risk for inflammation and issues with the liver. Serum iron levels are going to be done as well as a TIBC, or a total iron binding. Hemoglobin, and then we're going to be looking at a hemoglobin A and a hemoglobin F. Management for our thalassemias, erythrocyte transfusions. They're going to be doing chelation therapy, and they may even need a splenectomy. If two things, always remember, if they do, anytime that they are looking at removing the spleen in a splenectomy, It's another huge risk for an infection. So think about all the things that we need to do to prevent infection with these folks. And then if I say words that you guys don't know in lecture, I want you guys to look them up. Don't just skip over them. Make sure you're looking things up. And I do it on purpose because there are certain things I do want you guys to look up because studies have shown that if I tell you, you might forget, but if you actually look it up, it's like 9 out of 10 times more likely to remember it. So hint, hint. All right, complications of thalassemia is a thing called hemosiderosis. Um, Basically, what it is that there's so much iron in these folks that it can actually cause organ damage. A lot of you guys have seen. I'm trying to think of an example that that I could correlate with it. So if you guys have ever seen like the diabetic with the purple legs, they're not, sometimes they'll have sores, but it's not related. Well, not related in this case. But it's called hemosiderin staining. It's like the purple from like the knees down. That's because there's so much blood and so much iron in these folks that it's actually causing damage to the skin tissues and hemosiderin staining. And hemosiderosis, it's that same staining damage that you see in the skin. It actually happens in the organs. All right. Oh, I have my hair down and the fan's blowing on me because it's hot and it keeps tickling my face. So, oh, anyways, getting into leukemia. Leukemia, if you guys don't remember anything other than leukemia is a high, you guys will hear it said a high white count, but it's not just a high white count. Um, it is a high white count of immature immature white blood cells. So remember when I talked about white blood cells being the soldiers of the bunch? This is kind of where I pull that in. So in leukemia, the white blood cells, if we consider them soldiers, we have an abundance of soldiers out there, but it's not all the 18, 19, 20-year-old soldiers. It might be a 2-year-old soldier or a 12-year-old soldier. It's all these immature soldiers out there trying to fight the war, but because they're immature, they can't win the battle. So, leukemia is a blood cancer. Um, there's uncontrolled white cells. The blast cells are those immature white blood cells. Um, the bone marrow is producing all this extra stuff, but it's non-functional. Because the bone marrow is producing so much blast cells or immature white cells, we're going to see a decrease in all the other good cells that we need. Thrombocytopenia. Remember, look it up if you don't know. Leukopenia. Leukemia can be acute or chronic. So diagnostics, we're going to see a CBC. We're going to see a bone marrow aspiration because they would need to look and see exactly what the bone marrow is producing. And we're going to do lumbar punctures. Between the bone marrow and the lumbar puncture, we're going to be looking for these blast cells. Anything over, I believe, 30%, if there's 30% or more, these folks are considered to be in what's called a blast cell crisis. That means they can't fight off anything, not one little bit. So treatment for our leukemias, it's going to be different kinds of chemos. They might be on allopurinol, some sodium bicarb, all to try and keep all of this at bay. So getting into a few of the different things, chronic and acute, you guys can kind of look through these. I don't expect you to get super in depth with acute versus chronic. ALL, I put a picture of a kiddo because ALL is the most common form in children. We're going to see symptoms such as fever because they're going to have an infection that they can't fight off. They're going to be pale, excessive bruising. So, yes, kids get bruised. They are always doing something and bumping themselves and getting bruises, but this is excessive. It's going to be in places that they didn't bump anything. It might be on their forehead, it might be on their arms, legs, whatever. But it's past the point of just normal kid bruising. They're gonna complain of bone or joint pain. And then we're gonna see the lymphadenopathy or the hepatospleno. I can't even say it that fast. Hepatosplenomegaly. Um, CLL. Um, is one of the most common form in adults. So ALL is children, CLL is adult. Um, we're going to see lymphadenopathy. Those lymphocytes are going to be in the bone marrow, the spleen, the liver. They're going to be everywhere. CML, um, it has a higher mortality rate. Um, so these neoplastic granulocytes are made in the bone marrow and they're sent out into the bloodstream in massive numbers and they kind of take over and they take over the liver and the spleen. So higher mortality rate. All right, so we are skipping the questions. All right, multiple myeloma is a bone cancer. If you just remember that, that will help you get through. So, I'm trying to see. I don't remember what's on there. Um, so basically, um, in multiple myeloma, I'm gonna pause because the dogs are gonna bark here in a second. All right. So pathophys of multiple myeloma. Um, the myeloma cells are producing this excess of the gamma globulins. Um, so the antibodies that are secreted are increasing all the protein levels, which gums up the kidneys. So um, if you guys learn, I don't know how much you guys have learned about dialysis so far, but anytime anybody has kidney failure or even decreased kidney function, we need to really watch the amount of protein that they bring in because it can damage the kidneys pretty easy. Um, those myeloma cells also produce cytokines, um, which it destroys bones. That's why I say it's a bone cancer. It's the best way to describe multiple myeloma quickly. Um, with all of this, there's still decreased red blood cell, white blood cell, and platelet production because it's affecting the bone marrow and how the bone marrow works. So it's not producing everything that everybody needs. So we worry about, especially the bones are number one. The kidneys, they can go into kidney failure pretty easy with multiple myeloma because of those high protein levels. Like I said, it's a progressive bone destruction, decreased immunity because the bone marrow isn't functioning the way it should, so it's not making all of our little fighters and sending them out into the world. And then eventually death. Um, complications of multiple myeloma, like I said, kidney damage because of that protein, cardiac damage, pulmonary damage, and there's also a huge risk for blood clots. Things we're going to see, they're going to be easily fatigued, easy bruising, because remember they're thrombocytopenic, bone pain and fractures because those bones are fragile and they're very susceptible to breaking. Um, the bone pain is actually the multiple myeloma is causing the bones to break down. And because the bones are breaking down, the calcium in the bones is now entering the bloodstream because the bones are breaking down and releasing the calcium. So now we have hypercalcemia. Diagnostic testing, we're going to see bone thinning. We're going to see those bones actually have like a Swiss cheese appearance. We're going to see high immunoglobulins and high protein levels. And with multiple myeloma, there's going to be what's called a Benz-Jones protein that is specific to a multiple myeloma. Interventions for multiple myeloma, obviously pain, because I talked about it. Bone pain is super, super painful. Bisphosphonates, because that's going to try and help the bone from breaking down. They may need a stem cell transplant, and even chemotherapy because it is a cancer, so we need to stop the cancer cells. All right, moving on to malignant lymphomas. Um, Basically, this is a cancer of the lymph nodes or the lymph system. You can see this is a lymph node. All right, malignant lymphoma, cancer of the lymphoid cells, abnormal overgrowth of those lymphocytes. You can actually see solid tumors in the lymph system. There's Hodgkin's and non-Hodgkin's. Hodgkin's lymphoma generally hits the teens and younger adults and is positive for Reed-Sternberg cells. Non-Hodgkin's lymphoma is generally men and older adults. Hodgkin's has a better prognosis than non-Hodgkin's. And I don't remember if you guys were taught this in, sorry, we advanced too soon. I don't know if you guys were taught this in health alterations or not, but in Hodgkin's, because the lymph system is the garbage disposal system of the body, if somebody takes a drink of alcohol, a sip of alcohol, the body's trying to get rid of it because it's a toxin. It actually causes severe, severe, severe neck pain with just a sip of alcohol. All right. Moving on to thrombocytic purpura. Basically, this is just the body is making normal platelets. The platelets are normal, the number is normal, but the body is destroying them after they're made. Can be caused by an autoimmune dysfunction, which is ATP, or it can be a thrombotic thrombocytopenia purpura. So an autoimmune one, if you guys remember, anything autoimmune, that body is attacking itself. They're making antibodies against self cells. So in ATP, those antibodies are formed against the platelets. The antibodies attach to those platelets, and when the white blood cells are running around, they attack those platelets and kill them off. Platelets are being made and stored in the spleen. The platelets are being made slower than they're able to keep up with the amount of platelets that are being destroyed. So the white blood cells can attack the platelets that are running around in the vascular system, and they can attack the ones hanging out in the spleen. But they're destroying them so fast that the body can't produce enough to make up for the ones that are being killed off. In TTP, basically there's abnormal platelet clumping, clots, platelet plugs are happening without cuts, without trauma, without anything that normally would cause the platelet plugs to be formed. So once these clots or the plugs are formed, they'll start moving around the body, and eventually they can be severe enough and cause kidney failure, can cause an MI or a stroke, because that clot has traveled until it can't travel anymore, and now it's stuck in a place and causing brain stuff, heart stuff, you name it. All right, heparin-induced thrombocytopenia. After somebody has been on heparin, we're going to see a severe drop in their platelet counts. We're going to see like these microclots. It's not the normal like regular clot. They are very, very tiny microclots. We're going to do a platelet level and we're going to see a decreased amount. Assessment, excessive bleeding, with like brushing their teeth, shaving with a straight razor, all the things that we say. If your patient is at risk for bleeding, we don't want them to do these things. We're gonna see the bleeding in those. They're gonna be severely bruised. They don't have to even bump themselves; they just have to rub, and you're gonna see bruising. They're going to be thrombocytopenic with both of them. We're going to see low H&H levels, hemoglobin and hematocrit. But with the heparin-induced thrombocytopenia, they're going to have been on heparin therapy within the last 100 days. So the last 3 months or so, they would have been seen for something and be put on heparin. Treatment. We're going to give them platelets because they have none. We're going to keep them in a safe environment. We don't want them to bump themselves. We don't want them to cut themselves, and we don't want any trauma because they could bleed out pretty easy. We're going to suppress their immune system because that's the bone marrow, and that's where they're producing these cells that are going around and killing off the platelets that were formed. They're going to be on anticoagulants because we have clots and we don't want those clots to travel and settle in for a stroke or a heart attack. And we may also have they may also have a splenectomy. So remember what I said, they're going to be at a high risk for infection. So what do? We educate our patients. How do you decrease your risk of infection? Wearing a mask, not going out in public, all those types of things. Then we're also going to tell them to get all of their vaccinations, especially the influenza and the pneumonia vaccines. Because a lot of times these are going to be elderly adults, and elderly adults need to have their influenza and their pneumonia vaccines. All right. Hemophilia. They're just not clotting. I'm going to pause this here for a minute. All right. So hemophilia is a lifelong clotting disorder that is hereditary or genetic. Hemophilia A has to do with factor 8, and hemophilia B has to do with factor 9. Females can carry it and pass it to male children. All right, symptoms. We're going to see if they have moderate hemophilia, we're going to see bleeding after tissue trauma, whether it's brushing their teeth, whether it's scraping their knee. Severe hemophilia, they're just going to bleed with no cause. These folks are going to be easily bruised. We're going to see epistaxis, but the telltale sign of hemophilia is bleeding into the muscles and into the joints. These folks are going to have swelling, pain, stiffness in their knees, and their elbows, and their shoulders, ankles, wherever that blood accumulates in the joint. Diagnostics we're going to see, diagnostics we're going to do is a PT, a PTT, a bleeding level, a fibrinogen level, a platelet count, factor 8 and factor 9 assays. So if you look at all the diagnostic levels, they all have to do with bleeding, clotting, you name it. Management of hemophilia, obviously, we're going to do some transfusions, some blood transfusions. They may be on some prophylactic treatments such as desmopressin or Amicar. We're going to teach them to not do any activities that could cause any bleeding. And then we're going to do RICE, rest, ice, compression, elevation, for any bleeding symptoms. Our folks with hemophilia will present and say, I can't go back on my slides, but and we'll go these questions next week. But if somebody who comes in with hemophilia, they've had it for a while, they've experienced it, they know their symptoms, they will come in and say, I'm bleeding into my knee. I cannot stress enough to believe these folks because they know what their symptoms are, they know what it is, they have a good handle on it. Always believe your hemophiliac patients when they say, I'm bleeding into my whatever joint, because they'll be able to tell you. All right. Von Willebrand is also another inherited bleeding disorder. There's either not enough of the von Willebrand protein or it's not working properly. Von Willebrand is the protein that carries factor 8. So kind of the same idea as a hemophilia, but it also helps start the formation of a clot. So with von Willebrand, it's kind of the same symptoms that we see with hemophilia. They're going to have epistaxis, bleeding from the gums after they're brushing their teeth. Small injuries that should only bleed a little bit are now gushing blood because they can't make the clot. If they go into surgery, they have excessive bleeding. They're losing a lot more blood than would be expected. Or menage the I can't say that. Excessive periods. Diagnostics, we're going to look at their history. Again, we're going to be doing some bleeding time, some PTT, all the labs that have to do with bleeding and clotting. We might do a quantitative immunoelectrophoretic assay or an ELISA test, because we need to know why they're bleeding, why they're not clotting. Management for von Willebrand, obviously control the bleeding episodes. We're going to be replacing the von Willebrand in the blood, and then meds like desmopressin or DDAVP, which can be given IV, intranasally or sub-Q. This desmopressin is actually one that takes a very long time to give. It's last time I gave it, I think it was 10 mLs, and we gave it over 10 minutes. So it does take quite a while. All right. DIC, or disseminated intracoagulation. A lot of times you see this. A lot of times, or the most I've seen it is after childbirth. So when I talk about DIC, I explain it to you guys like flooring it with the brakes on. So the body's forming these micro clots or microthrombies all throughout the vascular system where it doesn't need it. These little clots are using up all the platelets, so the rest of the blood is not able to clot where it's needed. So you see they're clotting, but they're bleeding. These folks have a decreased oxygen level, increased sugar. I'm trying. Now, there isn't a whole lot on DIC, but just remember, it's pouring it with the brakes on. They're clotting, but because they're clotting, they're using up all of their clotting factors, their platelets. So now they're going to bleed other places. So it's not like you can just go in and bust up the clot because that won't work. And you can't just go in and try and slow down their bleeding because that won't work. Anemia guidelines. There's different types of anemia. And I want you guys to be familiar with all of them because they all have different symptoms and just different treatments. I was like dying of a heat stroke, so I turned the fan on and now I'm dying of it's freezing. Just turn it off. All right, so iron deficiency anemia. This is when there's not enough iron in the diet. You might see it with chronic alcoholism, malabsorption syndromes, such as like Crohn's, where they're not able to absorb what they need to. Also, iron deficiency anemia is seen in small children that their primary source of intake is milk. That's why we have iron fortified formula, because if they drink too much milk, they will be iron deficiency anemic. We also might see iron deficiency if they're bleeding. So like hemorrhagic is iron deficiency anemia. Folic acid deficiency anemia is a dietary, can actually be caused by certain meds. It's a big deal when people are pregnant. That's why they take folic acid in pregnancy to prevent neural tube defects. Vitamin B12 deficiency has to do with the kidneys, where the body's not absorbing the B12. So if somebody has a malabsorption syndrome, like I said, Crohn's, a lot of times we see this in patients that have had a gastrectomy because they can't absorb the B12 from the intestinal tract. We can also see it in like vegan diets where they're not getting all of the nutrition that they need. Symptoms of iron deficiency: fatigue. They're not able to exercise because they can't tolerate it. And then they're going to have these little cracks on the side of their mouth, like right here. And they're called fissures. So they're just basically cracks. B12 deficiency symptoms. The usual things: pallor, jaundice. But the big things with B12 are the glossitis, which is the big red beefy tongue. Paresthesia, so their hands and their feet are going to be numb and tingly, which then leads into poor balance. So if you don't have any feeling in your feet and these elderly folk are walking around, they could easily tip over. Um, Folic acid deficiency is basically the same as B12. That's supposed to say without paresthesias, not with put, so without. We see it most in folks that don't eat green leafy vegetables. Liver. Nobody eats liver. Lacking yeast, citrus foods, dried beans, and nuts. So it's actually more common. These are just some study slides. So iron deficiency, you can see here. B12 deficiencies there. Folic acid. There's our green leafy vegetables and our liver, and I'm not quite sure what all of that is, but it has to do with absorption. G6PD, I don't really, you can look at that, but don't get too hung up on it. Autoimmune hemolytic anemia, you can look at that too. It's just basically the body is killing off the red blood cells. The red blood cells lifespan is 120 days, but in autoimmune hemolytic is just a few days. All right. So getting into aplastic anemia. Aplastic anemia, these folks are going to be pancytopenic. Um, this just means that they don't have a lot of anything. They have a decreased amount of red blood cells, a decreased amount of white blood cells, a decreased amount of platelets. Aplastic anemia, they can have minimal symptoms, but it can even cause death. I keep forgetting I can't go back. Aplastic anemia, the bone marrow is kind of spongy. It's not the nice, healthy pink red. It is now like yellow and plastic, spongy type because the bone marrow is not functioning, so it's not producing all the parts that we need it to. Hemolytic anemia, is basically the red blood cells are being destroyed faster than the body can produce it. Can be an intrinsic factor, it can be an extrinsic factor. So it's red blood cells are destroyed. Here's a question. Skip it, skip it, skip it, skip it. All right. So getting into transfusions. There's different types of transfusions. We have packed units of red blood cells, PRBCs, or red blood cell transfusions. We have platelet transfusions, plasma transfusions, white blood cells. It doesn't happen very often that we give white blood cells, or a transfusion protocol. So red blood cells or PRBCs, um, we're going to give these when they've lost blood from trauma or from surgery. Anytime they've lost a lot of blood, we're going to give them the red blood cells. Platelet transfusions are given when those platelet levels are low, if they're actively bleeding, if they're not clotting. Plasma transfusion is more of a blood volume and clotting factors, not so much the specific red blood cells, platelets, whatever. It's to expand the blood volume because they're hypovolemic. Um, and then transfusion protocol, if somebody has their H and H drawn, hemoglobin and hematocrit, these levels are low. It's a whole transfusion protocol, a whole transfusion, the steps that we're giving blood. Transfusion reactions that we need to watch out for is febrile reaction, a hemolytic reaction, allergic reaction, bacterial, circulatory overload, or graft versus host disease. So a lot of times, most common transfusion reactions we're going to see are the febrile and the allergic. We'll get into the steps when I teach you guys in skills, but we take a set of vitals at the beginning, 15 minutes in, and at the end. So we are watching their temperature, what their baseline is, what it's like 15 minutes after they've started the blood, and then at the end of it. If they go up 1 degree Celsius or 2 degrees Fahrenheit, this is considered a febrile reaction. And this is just because the donor's blood and the recipient's blood are not compatible. We may continue with the blood transfusion and it just give them Tylenol. Just kind of depends on how severe things are. A hemolytic transfusion reaction is a very serious thing. This doesn't happen often, but it is out there. This is basically the donor cells come in and are mixed with the recipient cells and they don't mesh. So now they're destroying all the red blood cells in the blood. So that is a major emergency. Um, there's an allergic reaction. They might itch. Sometimes they could go into anaphylaxis. Um, but if it's not severe, the doc may just say, give them some Benadryl between units and you're good to go. Bacterial reaction has to do with because the blood was sitting, it may have picked up some, grew some bugs in it. Circulatory overload we see more often in frail little old ladies if we're giving their blood too fast. It's like when we give them too many IV fluids. You're going to hear it in their lungs. There's going to back up into their lungs. And then they might have a graft versus host disease where it's attacking the kidneys. In any case, with our blood transfusions, we are going to stop them immediately. We're going to get rid of their blood, hang normal saline, unless it's a transfusion reaction that we're just going to treat, like with Benadryl, Lasix, Tylenol. So always whatever the doc decides, but NCLEX world, it is stop the transfusion, hang a new bag with new tubing of normal saline, call the doctor. And I think the rest of these are just questions. Maybe.